to this NASP webinar where we are going to be launching some new guidance that the Royal College of Occupational Therapists and the National Academy for Social Prescribing have been collaborating on the last few over the last few months. It highlights how social prescribing link workers and occupational therapists can work together effectively in practice. I'm just going to give it a few more seconds before we get into the housekeeping and the detail, just so that people can trickle in. But you are very, very welcome. It's great. It's great to see you all here. Just going to give it another 30 seconds or so. Great. So, yes, as I said, welcome everybody. It's really great to see you all here. Today, we are all going to be talking about some guidance that the Royal College of Occupational Therapists and the National Academy for Social Prescribing have been working on over the last few months to explore some examples and some best practice on how link workers and occupational therapists work effectively together in practice. Before we get into the meat of the session, I'm just going to take us through a little bit of housekeeping for today. So if we can go to the next slide, please. So we will be recording this webinar. Everybody that's signed up to the webinar will receive the slides and the link to the recording, and you will also receive the link to the newly published guidance, which is really exciting that we're launching that today. The recording of the webinar and the guidance will also be on NASP's website, and the guidance will also be on RCOT's website as well. We'll be using the Q&A function, and we'll come to questions at the very end of all of the presentations for our speakers. So please do use that Q&A function rather than the chat to submit your questions. You can see that at the bottom of your screen. The chat function is where it would be great if you could introduce yourself. We're seeing today very much as a conversation starter and very much as a chance to kind of open up that essence of collaboration. So please do utilize that chat for networking, saying where you work, what your role is, and connecting with each other. Please also use the chat if you have any technical issues, and we've got members of the NASP team working busily in the background to make sure things run smoothly. So if you are having any problems, pop it in the chat and we'll come to it as soon as we can. Closed captions are also available. The bottom of your screen is also the place to turn these on. And I also just want to remind us that everybody comes with different experiences and viewpoints as we kind of look at this topic together. So let's keep an open mind and really learn from one another's experiences in this space today. And I'm, yes, very much looking forward to the conversation. So we will get into the meat of the session, which Joe and I are co-hosting this session today, and we'll introduce ourselves in a little while. We're then going to be hearing from Claire, who is a specialist occupational therapist in older people's mental health and dementia. We'll then be hearing from Kimberly Dutton. She's a senior occupational therapist and primary care lead at Sport for Confidence. And then we'll be hearing from Yasmin Zaman, who is a social prescribing link worker at Sea City Partnership in Southampton. I will introduce them all properly later. But first off, Joe and I are just going to take you through a little bit of context and background and some more details about what is included in this guidance that we are launching today. So for those of you who don't know me, I'm Monica Bolton. I am the strategic lead for healthcare integration and neighbourhood health here at the National Academy for Social Prescribing. So do a lot of the work that NASP do on the social prescribing link worker learning offer and clinical engagement, as well as exploring the importance of social prescribing within neighbourhood health models, of which this guidance is hugely relevant. The National Academy for Social Prescribing is an organisation that was set up back in 2019 to support the study and practice and advancement of social prescribing, both in England and the wider UK nations, but also globally across the world, to sort of see how social prescribing is relevant and useful in a variety of different contexts and settings. And I will hand over to my co-host Jo to introduce herself and the Royal College of Occupational Therapists.
Thank you, Monica. So first of all, apologies. I'm a bit snotty and grotty today. I'll do my best to turn the camera off and mute so nobody has to hear me blow my nose. So I'm Joanna Ballum-Smith. I'm an occupational therapist, and my background is in work and health generally. So that's occupational health and vocational rehab and lots of different parts, but all about returning and retaining work. I have worked at the Royal College. I'm here just on a 18-month fixed-term contract to do all things work and health, that's policy and influencing, and also practitioner support and guidance, of which this is a very important part. So the Royal College of Occupational Therapists, so they're the professional body and the membership organisation for occupational therapists. There's over 36,000 members, and we work in hugely diverse areas of practice, which we'll cover a bit later. But that's who we are. Thanks for having me.
Thank you, Joe. And it has been, yeah, such a wonderful thing to work on this guidance together and really come to recognise some of those synergies, but also really important differences of the occupational therapist and social prescribing link worker role, and working with the three other speakers on the call to really demonstrate how that is working well in practice at the moment. It's great to see so many people connecting in the chat. Please do, if you've just joined, just continue to introduce yourselves and network with one another in the chat, and use the Q&A function to ask questions of the speakers. We're going to be coming to that right at the end of the presentations. So if we can just go to the next slide, please. So we wanted to just start off by talking about why we feel that this guidance is quite a timely for us to be launching and publishing this guidance today. It's coming at a time, as many of you will be experiencing on this call, where NHS systems, social care systems and community systems are under huge amounts of pressure. People are living longer, which is a huge success, but often in more years of poor health. There is an increase of people living with long-term conditions, and that is having a marked impact on health and social care demand. It has led to not just pressure on the system, but also on the workforce who are supporting those individuals. And of course, as I'm sure we can all agree with on this call, people deserve to live well in a way that is receiving support that's beyond medicine, through offering that more holistic support rather than just a short-term medical intervention. We must recognise that the impacts, particularly on things like long-term conditions, have a direct correlation to those social determinants of health, which often require a much more holistic, person-centred and long-term intervention. We're also hearing really clearly from individuals that they want more choice, they want more control, and they want more meaningful conversations about what actually matters to them to be incorporated in their health and social care plans. And much of this, everything that I've just described, is driving this shift that we are now seeing towards what is being termed as neighbourhood health. And those neighbourhood health models have the ambition to be more localised, to have more personalised, person-centred care with that greater focus on prevention and preventative health. And one of the key delivery mechanisms for neighbourhood health will be multidisciplinary teams, which is why collaboration between the OT role, the social prescribing link worker role, is both necessary and important, so that people can get their right help and get the right care, the right help, the right support at the right time. Joe.
Mute button is very hard to find today. So we've seen this huge shift that Monica was describing, and it's so exciting for our professions, particularly because we've always had that really holistic lens. We understand the importance of participation and meaningful doing, and we have been building up this evidence base of what we do in that context. And we're really starting to be seen as the leaders in this and really important key players. So quite early on in my contract last summer, we were approached by a civil servant in the Department of Work and Pension and Health and Social Care, who was on the Keep Britain Working team, and specifically saying, right, we see what you OTs are doing there, we see what you social prescribers are doing there, you have to be a part of the solution. Could you do it together as well? And that started this conversation between our organisations, and it's just the most perfect synergy, because it matches up really nicely with this move away from kind of purely condition focused to this wider picture of what impacts a person and their everyday functioning. And it fits as well with one of these three key NHS shifts from acute to community, and that's where so much of life happens, and really important things happen that impact health, and there's just this huge growing shift and recognition, is that a word? Recognition, that this is where the power lies, and where the shift is moving to, and we're really well positioned as professions to do this, particularly together.
And we're
So
seeing
yeah,
continued expansion of those approaches, aren't we, Joe? Where link workers and occupational therapists are specifically supporting people to understand what matters to them in the context of work and health. So really ensuring that people are having that more holistic and person-centered conversation, and we're sort of waiting for continued expansion of those in upcoming policies as well, which is really exciting. And again, as you mentioned, why this is so timely at the moment. If we can move on to the next slide, please, Audrey. Thank you. So the overall aim, I think, of this guidance, and particularly that wider partnership that RCOT and NASP have been developing, is recognising that fundamental shift that is needed across health and care systems, and that current reality that we, as I mentioned before, that we're often experiencing in our roles is that we're operating quite often in silos. And this, for the person that is at the end of that, can lead to duplication, it can lead to gaps in support, and uncertainty about where those responsibilities sits and who might be doing what in somebody's care. And ultimately, that means that individuals are having to navigate multiple services, they're having to repeat their story quite often, or ultimately receive care that isn't fully coordinated or as coordinated as it could be. However, both OTs and link workers are already helping to shape a different reality for people, because they recognize what people need, that personalized whole person support focused on what matters to those individuals. And what this guidance really is aiming to do is build on that shared vision, that shared value that sits at the heart of both of those roles, and highlight how closer, more joined up working through the examples that we've identified can really strengthen not just the outcomes of that individual, but how that individual is being supported throughout that whole journey. And that means that there is shared ownership, there are more clearly defined roles, and that very embedded and collective focus on the person rather than on the service that is being provided. So the person is very much at the team is sitting around that person rather than the person having to go around that team. And at its best, as we've kind of seen through some of the examples that we've identified, collaboration between OTs and social prescribing link workers brings together that kind of clinical, functional, with that social expertise to address not just health needs, but also confidence, independence, and that all important social connection. And we're in the next slide, we're just going to highlight some of the sort of key roles and responsibilities for the benefits of the audience today what the kind of unique roles, differences, and overlap is of link workers and OTs. So, Joe, I'll hand over to you first to go through the left-hand side of this slide.
thank you. So if it's all right, I'll just talk quite broad because occupational therapy, we're such a diverse profession. We work in such different areas. I thought it would be handy just to describe. So any area of practice where occupational therapists work, our focus is on occupations. And by occupations, we don't just mean work, although we include work. We mean meaningful doing, meaningful participation. And that could be getting washed and dressed. We might be doing kind of equipment type things. It might mean going to the pub. It might mean going for a walk. It might mean socializing. So it can anything that meaningfully occupies our time. And we work with across the lifespan, so beginning of life, end of life, and everything in between. We are HCPC registered, so we're kind of a regulated profession. We bring kind of clinical governance and that potential kind of escalation point for kind of clinical risk management, that kind of thing. We're dual trained as well, so it's and I don't like that term. I prefer the term holistic, but holistically trained, because it's not just mental health, physical health. It makes it sound like just that, but it's anything that humans can experience, whether that's a condition, a diagnosed condition or undiagnosed condition or symptoms, but also we're trained to assess an activity. So where anything that they're wanting to do, we can use activity analysis to break that down into the minutiae of what it requires of a person and the environment in which they need to do that task. And that's the physical environment, but it's also the cultural environment and the time of day environment and the temperature. It's everything about doing a task. And also to say we work in across many settings, including health, social care, community, independent and private practice as well. So we're a really diverse bunch. You might see an OT that's really specialist in kind of older persons rehab, or somebody that's really specialist in children and young people, supporting somebody to stay in school. And once you know an occupational therapist, it's unlikely that you'll understand the whole of occupational therapy because it's so diverse. OTs often don't understand OTs, so just don't worry if it's confusing, because we are a complex bunch, but we always like talking about it.
Thanks, Joe. And we've got some of those specialist roles on the call today, and also speaking. So yeah, looking forward to them bringing some of that nuance to life. And I'm sure through the link workers that are on the call, through hearing Joe just speak, can already start to identify some of those complementary strengths that link workers bring to the wealth of expertise that occupational therapists have. For those who might be newer to the social prescribing link worker role, it is a non-clinical but personalised approach, taking a very co-produced sort of approach to supporting the improvement of somebody's health and well-being. Link workers do this through building trusted relationships over time. They take a holistic and asset-based approach, so they are asking people what brings them joy, what strengths they have, and really tapping into those to help people get from where they are to where they want to be. Similarly to OTs, they are looking at barriers, but this might be barriers that are more aligned to the social determinants of health and those barriers that individuals might be facing to access some of those health bringing, life bringing activities. They are really looking at the emotional and practical needs of an individual, quite often supporting people with their housing, with their finances, with debt, and helping to improve social connection, so that that person has a better overall sense of their well-being. At the absolute heart of the social prescribing link worker role is co-production. It's all about the individual that they are supporting being in the driving seat of that conversation, and very much having a part to play in the plan that is produced with a social prescribing link worker. But I think the beauty of the role is the amount of time that they are able to spend with a patient to really get to know them, and sort of peel back those layers to understand what will make the most difference in that person's life. Similarly to OTs as well, link workers are in a variety of different settings. So there is a universal social prescribing offer with link workers predominantly based in primary care, so in GP practices, but we are seeing an emergence of more targeted approaches based in secondary care, in the voluntary sector, in citizens advice, in local authorities. So again, a really eclectic and growing workforce, which is really exciting. But I think the takeaway for the link worker role is that at its absolute heart, it focuses on relationships and connection, and that whole person support. So hopefully, just by the way that Joe and I have articulated these two roles, both OTs and link workers on the calls can identify how there is complementary approaches of these two highly skilled professionals working together to support individuals with that sort of unified motivation of really understanding what matters to that individual. If we can go to the next slide, Joe and I are just going to highlight a little bit about what is in the guidance. And as I mentioned earlier, we'll be sharing the guidance alongside the recording of this webinar so that you can look at it in more detail at your leisure. So Joe, do you want to kick off?
Sure. So one thing we wanted to highlight really strongly in this guidance was the shared values and principles that we have as professions, so we certainly highlight that within it. But at the same time, we're super clear about the distinct boundaries between our professions and that fabulous overlap that we have. So we do our best to be clear and articulate that well. Whilst this guidance certainly isn't telling you what should be happening in practice, this is a kind of an aspirational text to support practitioners to move towards working together and to support that brilliant practice that we know from the case studies today and others, and from some fabulous pilots that have been going on, that when we do work together, it's wonderful. So we wanted to support those that have those opportunities to do that in the best way possible. Shall I hand over to you for guidance on risk management, Monica?
Yes, so I think that is sort of establishing role clarity and understanding one another's role can provide a really good foundation for establishing things like referral criteria and understanding who is holding responsibility over risk management, how you can support one another through peer supervision, connecting with each other to be from each other, the unique strengths that each roles are bringing. And we, as Joe has already alluded to, this is by no means a blueprint or something that we know can be necessarily lifted and shifted into every system, because all systems are incredibly unique, and the roles that you might have within the context of this guidance will vary widely, and certainly expect those to be shaped and influenced by the system design and capacity that you're working within. What we hope is that this will really provide that practical framework that can be adapted to a local context, and lean into those sort of core principles that underpin being able to set up things like referral pathways. And at the heart of it is really ensuring that clarity and understanding of one another's roles is absolutely at the heart of any collaboration that exists, and you start to build on. We recognise that in the guidance that collaboration might actually start quite informally, with joint discussions, with brief day-to-day conversations, and those really can be a great starting point. In fact, even today might be a good starting point to just sort of think a little bit differently, or start that conversation about how collaboration might pursue. And so we would just really encourage that where formal pathways are perhaps not established, this guidance really sort of encourages that proactive approach to connecting with one another, introducing yourselves to one another, and that can often be the start of those sort of really sustainable referral processes, and a combined understanding of risk management, and governance. So we're going to start to explore this. I'm conscious of time, but there will be loads more chance to have a look through the guide once we send it out with the webinar recording. Joe, I don't know whether there's anything that I've missed that you want to pull out
No,
before
no,
we
I think
hand
that's
over to the
great.
case studies. Yeah, I mean, I think that the best way to do this is through exploring case studies, isn't it? And we've got three OTs, well, two OTs and one link worker who is going to be talking to us today about their own experiences, and have been absolutely core and crucial to the development of this guidance. So my first thing to say is an absolutely massive thank you to Kim, Claire, and Yasmin for all of the support that they have provided on this document. We're first going to be hearing from Claire. Claire is a highly specialist occupational therapist in older people's mental health and dementia, and she works in Bradford District Care NHS Foundation Trust, with an advanced and extended role in dementia care, including that of diagnosis. Claire has, I can't believe this, 23 years experience working in mental health, including both ward and community environments with working age and older adults, and adults with learning disabilities and autism. So a huge amount of expertise and experience here. Claire has a real passion for equity and care for underserved communities in particular, and innovation in services. So a perfect person to be contributing towards this guidance. Claire currently works as a pathway lead in the Young Onset Memory Service, and as clinical lead to occupational therapy staff across older people's mental health services. So it's a joy and a privilege to be introducing you today, Claire. Over to you.
Hi, everyone. Yeah, that's a great introduction. Thank you very much, Monica. I'm going to talk to you about three different case studies today, one of which I was involved in, and two others from two other different services across Yorkshire, not necessarily in Bradford, that were relevant to this guidance that we've all worked together to put together. So the first one I'm going to talk to you about is the person I was involved in. Now, I found out about social prescribers by accident. It was through an informal chat in the team, and an informal invite for them to come to meet with us, and for us to understand more about their role. And while there, I discussed this particular case that I'm going to speak to you about today, and we started collaboration from there. So this is about a gentleman in his late 60s, and as I work with some people with complex mental health conditions, including health anxiety and general anxiety disorder and social anxiety, this particular gentleman had health anxiety. He was under secondary mental health, community mental health services for about a year. He worked with me all through that time, so I knew this gentleman very well, and I knew his family very well, people he lived with, people he spent time with. So in this case, he was somebody, well, he was somebody that had got to the point now where we'd finished our work. I'd done lots of graded exposure into the community with him, I'd done lots of walking, talking interviews, anxiety management, work with his family around understanding his anxiety. And it was time for him to go back to primary care. But I also felt with the complexity of the family dynamics, he felt himself that he would like some time away from family and some time to do something of his own. And I worked with the social prescriber through joint visits because his family didn't necessarily agree with this point of view. And there was disagreements within the home throughout the year that I was working with him. So I would work jointly initially with the social prescriber, which isn't usual because normally primary and secondary care are separate. But we decided in this incident, due to helping risk management and helping the social prescriber become comfortable with the family dynamics, that we'd do a couple of joint visits. This went very well, and he got on with the social prescriber very well. And again, we were looking for something that he would be interested in doing in the community that isn't related to a mental health group, and isn't related to mental health services. And for some time away from his wife and family for himself, as they all were getting time of their own. So he was interested in a walking group. He was interested in joining a men's group where he could talk about cars. So the social prescriber, also, he had done some anxiety management with me that included some mindfulness. And this social prescriber happened to be trained in mindfulness and happened to have supervision from a mental health coach within the GP surgery. So this worked very well for me to be able to pass this gentleman and his care over to her, considering he didn't need secondary mental health care anymore. So he got the opportunity to continue to practice mindfulness with this lady being a social prescriber. And he also had the opportunity to get some space from family and go and explore some community groups and some confidence building with this particular social prescriber. This led to him being transferred back to primary care. So he was no longer in mental health services. We never advocate for people being in mental health services longer than they need to be. And this did really work out for this gentleman. He never came back to services. And the social prescriber was able to get supervision from a mental health coach within her service. We also put a plan together as for when, if his mental health had deteriorated in that time, that he was back under primary care, that there could be some contact from the social prescriber to myself and a task built into the electronic system for him to be referred back to us. And the social prescriber went away, from my point of view, with a care plan to work with him, with being connected back into the community in a safe way where he had support to do that. So that's the first. Can we move to the next slide, please? That's the first case. This case is where an occupational therapist is an aging well practitioner and working in primary care services, targeting those that don't engage with the GP much in an area where there's deprivation, there's different socio-economic backgrounds, and an occupational therapist works there in this age and well service with 3 social prescribers. And they work with all sorts of people, including people where there's frailty issues, complex frailty, which the occupational therapist does assessments and interventions with, and then simple frailty needs, which some of the 3 social prescribers have some training in helping and supporting with the frailty in order to link people back in to the community and reduce social isolation. So this occupational therapist would meet with the social prescribing link worker individually once every 3 months. And this would be to go through cases that they are working together in terms of aging well and frailty, and also to go through anything complex that they may need to discuss. And also to identify training needs exchange information and ideas, and have some informal restorative conversations. With the social prescribers, they also had group supervision once every 3 months as well, all together with the occupational therapist, which then helped them understand, as the project in Aging Well, how that was going, what they needed to do next. Is again exchanging information, ideas, talking about complex cases. Each of these social prescribing link workers had a project of their own. One, because of the deprivation of the area, one social prescribing link worker trained in homelessness working and did a project around homelessness. Another social prescribing link worker was doing a training on cancer care and how they can support cancer care. And another social prescriber was working with people with long-term conditions, more on the frailty pathway than the other two. Again, supervision was a safe space, is a safe space, continues to be a safe space for them to have supervision on a group remit once every 3 months, individual with the band 7OT. And then the clinical director meets with them individually once every 3 months as well of the surgery. Can I move to the next slide, please? And this is the last case I'm going to talk about. And again, this is about somebody in primary care with a long-term condition where the occupational therapist and the social prescriber has worked together to enable a lady with fibromyalgia to have to be able to do more gardening, and then by proxy to link to community groups that would do gardening, and where this case led. So yes, this lady has long-term condition of fibromyalgia. The physical symptoms, as we all know, can be really horrendous. They can be exhausting, including fatigue, including pain, including what needing to stay in bed, which can then affect somebody psychologically, socially isolate them. So the occupational therapist was involved to do an assessment of their current abilities while living with fibromyalgia, which includes pacing and energy conservation advice, equipment purchase to help them be able to do gardening. They were able to look at their mobility and how that and their pattern of movement and rest and make an assessment of that. Also looked at risk assessment, which is what occupational therapists routinely do when they're assessing occupation, and looking at what they could put in place intervention wise to reduce risk and enhance well-being and enable the person to engage in gardening. And then referral to social prescriber. Along comes a social prescriber who again understands, like what Monica and Joe have said before, around goal setting, around the holistic, the person, around well-being, around the social determinants of health. And they were able to help once an electronic referral was done through the system, which is actually there now as a permanent referral way of referring, which is also helpful for OTs and social prescribers alike. So they would joint visit, and the occupational therapist, having already completed their assessment and advised the interventions, joint visited with the social prescriber, and they would do a few visits together so that they could all get used to understanding each other and what the actual interventions and next steps were going to be. Then the social prescriber has carried on visiting, putting in place what the occupational therapist has advised through, the interventions around, just repeated around energy and conservation and around using the equipment with written advice, so that the social prescriber isn't going outside of their own remit. They just refer the person back to the written advice around the interventions and then signposting to groups, and also in helping integrate the person into groups. That's what the social prescriber would do in this case, to help confidence building. And the OT would supervise the social prescriber on more of a on more of an informal basis, but much more than usual, as well as the formal supervision. What happened here in this case was the lady ended up being able to volunteer. The lady ended up being able to have less visits to the GP, and the social prescriber and the OT together was able to enable the person to reach their goals.
Claire, I'm conscious of time, and that feels like a really good place to summarise at the
Yeah,
end, where that collaboration has led to not just benefits for that individual, but actually benefits for the wider system, which we started talking about at the very top of this call, the pressure that systems are under. And you've just really eloquently described how the join up of these two roles can be really powerful in that regard, but also in every of one of your case studies, that exposure to one another and how that enhanced both the OT and the link workers' overall support really shines through. So some, yeah, really great examples that you have shared there. Sorry to need to cut you off, but
yeah,
we'll hear from you
fine.
again at the end when we get to the questions, and that's exactly what I want to make sure that we have got the time for. So thank you, Claire. I'm now going to hand over to Kim. Kim is a senior occupational therapist and primary care lead at Sport for Confidence. Sport for Confidence, if I can say it correctly, is an organisation that utilises occupational therapy, physical activity, and the voice of lived experience to address barriers to accessing physical activity and sport, tackling inequalities, and provide the best experiences for people and communities to engage in activity that is meaningful to them. It sounds like a wonderful organisation. Kim's role is based from GP surgeries, working with individuals with a range of needs spanning from frailty to complex psychosocial needs to those with learning disabilities attending their annual health checks. Thank you, Kim, for joining us today. Over to you.
Thanks, Monica. That's a really lovely introduction. So I don't feel that I need to say anything more, actually. Monica said that so well. So yes, I'm Kim. I'm a lead occupational therapist in primary care at Sport for Confidence, and my main role is based out of GP practices. I work in a primary care network based of 7 GP practices. But the case study I want to talk a bit about today is actually one um, from a leisure centre site. So Sport for Confidence actually works across many spaces nationally and locally, so leisure centres to GP practice to community spaces. So want to talk about a case study of a young lady in her 40s. She had long-term conditions. Also, apologies, sorry, I just realised I haven't got a slide deck, so I will be talking at you all. I hope that is okay. Yes, a young lady in her 40s with fibromyalgia who lives with her husband, previously worked in an office but hasn't worked for um, quite a few years actually due to fibromyalgia and a previous spinal injury that's caused chronic long-term back pain. She works with a walking stick now, and one of her biggest sort of areas of problems of its anxiety, her lack of belonging, her lack of occupational imbalance, and lack of access to meaningful activities. The social prescriber from her GP practice reached out to the OT to do a referral, and the referral was initially based on how can we support this person to be more active, and how can we support this person to be more into fitness, as it was initially sort of said. And it opened up and created really honest conversations with the social prescriber, who was really open to discussing, because they recognised that the original goal of there was an original goal of getting active. However, the barriers around being active and participating in activity were more complex due to the fibromyalgia and the chronic pain, as well as a lack of confidence, a lack of reduced anxiety or anxiety, and a loss of routine. So it was a great foundation to start off, that the social prescriber highlighted that and referred appropriately on to the OT. So that led on to a holistic occupational therapy assessment, highlighting the barriers, reduced stamina, increased pain on exertion, loss of routine, and anxiety in social settings. The occupational therapy intervention was looking at routine. It was a psychoeducational approach, looking at sort of linking to correct service at the correct time, long-armed advice, guidance around employment, and how can we translate the skills that we've learned in our physical activity sessions and interventions, and how can we translate that to work activity, exploring the impact of fibromyalgia, chronic pain, and spine injury on daily occupations and daily function, looking at occupational performance routines, roles, identity, and the quality of life. What was really, really nice about this is that the occupational therapist was able to work on the functional side and bring it alongside the social prescriber, closely working together to look at exploring other barriers to engagement, which we looked at the fatigue, the pain flare-ups, the reduced confidence, the social anxiety, while the social prescriber was able to look at some of the other barriers, connecting to one of the things that we actually worked on with this lady was to get her access in her local leisure centre. The social prescriber was able to help negotiate some of them other barriers, such as making the appointment, learning how to use technology on the phone to book through the app, looking at how filling in forms, and those other small sort of components that aren't just small, but actually real world barriers to someone still facing barriers to participation. Together, it was really well. Another sort of highlighted use of working together was anxiety was a real thing with this lady, and coming into a leisure centre to begin with was not the right space for her, but work with the social scriber to find other community assets that was a safe space for that lady, utilising the knowledge of the social prescriber to look at what community assets were available and what were safe spaces was really, really vital, and using that knowledge to connect to other services for that person, whilst the OT worked on the psychoeducational approach, looking at activity and energy conservation, working on the functional aspect, whilst the social prescriber was able to use the community knowledge of finding the right services and the right local support for that person together. Was really, really a nice combination of how both roles lovely complement each other. Throughout the work as well, the social scriber was able to link in quite well, building a good relationship together between ourselves, and that we could do sort of our check-ins by the social scriber, so helping maintain that engagement with that person. So checking in after her activities, helping problem solve those practical barriers, as I said, negotiating technology, telephones, reinforcing progress and achievements, and encouraging that sustained participation in community activity. What I think we know from a lot of our patients is I don't like to use the word hand holding. When we've got that right support there at the right time, stepping away too soon can undo all the good work that's been done. So utilizing that check-ins with noting the social prescriber to have that sort of that initial sort of checkpoints and reinforcing that throughout was really, really vital. I think this is a real quick case study of how they can work together, but I think occupational therapists and social prescribers working together to bridge that clinical function, assessment, and rehabilitation with community participation is so vital. The occupational therapist can provide that therapeutic assessment intervention, while the social prescriber can link that person to enable connection to meaningful and creative community opportunities. And, overall, that will sustain further engagements and reduce that reliance on healthcare services. But happy to answer anything more and discuss more, lots of discussions at the end.
Yeah, that's really great. Thank you, Kimberly. I mean, you said it was a short case study, but just as you were talking through it, I could just see different points of that guidance that we have totally drawn from your experience and has been so informative when we think about the strengths of both of those roles and how they have contributed just to that individual's overall well-being and sense of self and purpose, which is just, yeah, absolutely brilliant to bring to life through that case study. So thank you. So last but by no means least, we're going to hand over to Yasmin to speak to the social prescribing link worker perspective. And there's a comment that's come through in the chat about asking about what is the type of support that a social prescribing link worker can provide. And Claire and Kimberly have kind of alluded to that already, but I'm looking forward to hearing from Yasmin, who I'm sure will help bring some of that perspective to life as well. So Yasmin is a social prescribing link worker for Sea City Partnership in Southampton, as I mentioned earlier. Yasmin's background is in global health communication with UNICEF, university health promotion, and an MBCT therapist and trauma yoga teacher working in psychiatric mental health. So a huge wealth of experience beyond the role of a link worker. So over to you, Yasmin. Looking forward to hearing more.
Thanks very much, Monica. It's good to be here, and I'm looking forward to sharing a few case studies with you of joint working between social prescribers and occupational therapists in Southampton Sea City Partnership. First slide, please, or next slide. Thank you. Just a bit of context, Sea City Partnership consists of 4 surgeries within the central and part of the west of Southampton, which are the most deprived areas of the city. 29% of this area falls within 10% of the most deprived areas in England, with high rates of crime, unemployment, where we have almost 12% living with fuel poverty. Next slide, please. So in this first case study, we received a referral from an OT working for East Hampshire Community Learning Disability Team to support a 62-year-old woman with a learning disability, mild sight impairment, and help her connect to social activities. The OT had already helped the woman with confidence building activities and helping her engage more within the supported living accommodation that she was in. After the first meeting, the first appointment with the lady and her support worker, she very clearly expressed that she wanted to go on short walks and visit local cafes on a regular basis, providing she could go with the same person or befriend her each time. I was made aware at that meeting that she could become agitated in public, for example, if there were too many people. So a relatively simple referral from an external OT into the practice. However, it took almost a year searching for a befriending organisation amongst local and some national befriending organisations, because none of them could guarantee the availability of a volunteer, the same person each week. And also there were concerns about a volunteer befriender being able to manage the lady's behaviour should she become agitated in public. Eventually, we were able to connect the lady to an organisation, a pen pal organisation, especially for people with learning disabilities and other types of disabilities, so that she could socialise in a way that was appropriate to her needs at the time, with a little help from a support worker. And fortunately, the support worker offered to accompany her on weekly walks. Because this took a long time, although, as I said, a relatively simple referral, we kept in touch, regular updates with the OT, just to let them know that things were continuing and hopefully help them understand the reality on the ground. But yeah, it was really lovely to receive a referral from an OT working outside of our practice. Next slide, please. So in this case study, we received a referral from the GP for an elderly Muslim man to help with housing support. The initial SP visit, it was very clear that the man was living in completely unsafe and unsuitable conditions. He spoke to us about financial abuse from his landlord, and he had concerns because of his age about how to go about arranging a Muslim burial, particularly as he had no other family or kin nearby. We immediately had discussions with the PCN frailty team and the GP about our concerns. And then it was agreed that I would make an emergency safeguarding referral to adult social care for a care needs assessment, also referred to the 60 plus floating support for urgent rehousing. And we also contacted the welfare officer at the local Muslim council to help with communication and also provide the information for Muslim burial arrangements. I set up the MDT. So we had an OT from the Community Independent Service, which actually sits within adult social care. We had a housing officer from floating support and also the welfare officer from the local mosque. At the initial MDT, there was an update about the sensitivities involved in this case and the complexity. And we came up with an initial plan of action that the OT and myself and the housing officer would make a first visit together, and then a second visit would take place with myself and the welfare officer from the mosque. So after the initial visit, where the OT assessed for functional and environmental risks for the man, she made an immediate referral for safety equipment and adaptations to take place in the man's home for the following week. And if you know anything about adult social care, that is super fast. She also made a referral to the additional assessment team and what else? Oh yeah, the Community Independent Service to increase the housing points to help accelerate his being allocated suitable housing. The housing officer was looking for sheltered accommodation within the central area because the man said that he wanted to be closer to the shops and a pharmacy because of his increasing frailty. And on the second visit, when the welfare officer and I visited together, the man disclosed more about the financial abuse, his concerns about being evicted by the landlord now that he'd involved outsiders, and he wanted more information about burial. The GP met with the gentleman again to discuss his end-of-life wishes and set up an advanced care plan. Throughout working on this case, the OT and myself had regular debriefing sessions, formally, informally, in meetings that we'd arranged or outside the gentleman's house, sometimes with the housing officer and the welfare officer. And it was my responsibility to coordinate the communication and make sure that all the actions were carried out. One of the wonderful things about working on this case was that the OT, because of the close working relationship, became a go-to person within adult social care. So if we wanted to bypass the bureaucracy in adult social care and we had any queries, then we would go to them, or we still do, and vice versa. And I think it's a really good example of person-centered approach in joint working. In this final case study, very quickly, we are very fortunate in that we have an OT within the partnership who sits within the mental health team, and she referred a 50-year-old woman with significant mental health conditions, sight impairment, damp and mold in their house, and living in a block with no lift. So the referral was for to help with benefits, support with the damp and mold, and to follow up on a Care Act assessment referral that she had made but had not had any response from social care about. The OT continued working with supporting the woman with her mental health, and we succeeded in helping the lady apply for personal independence payment, referring her to the local environmental agency for the damp, and also advocating on her behalf with adult social care to make sure that they were escalating her being rehoused. So we're very fortunate, as I said, because we have a in-house OT. So there's a frequent cross-referral, and also the OT provides us with monthly reflective practice sessions. So there's a lot of benefit to that. And I hope it's been interesting just to see the different ways in which Southampton Sea City Partnership have interacted with OTs. Thanks very much, everyone.
Thank you so much, Yasmin. And yeah, that kind of practice and a chance to really kind of learn from one another seems to be a theme in all three of the presentations, as well as the incredible patient outcomes that have been achieved through that collaborative working. So thank you all again for the presentations, but also for your vital contributions to the guidance itself, which we will be sharing later today. We've got a couple of time for some really quick questions. Yasmin, there's a couple around the link worker role. So one on how much time do link workers get to work with a person, and also what outcome measures are being used by link workers, and how do you measure the impact of your work? I wonder if you can just speak to those two first of all.
In terms of time, we always, when we first meet with a patient and describe the service, which they're usually unaware of, we let them know that they have more than a 10-minute or 15-minute GP appointment. They have between 30 to 60 minutes, could be longer, depending on their needs and what they've been referred for, and that they can have up to from 6 to 12 sessions spread over the year. But it really varies. If on the rare cases, the rare times when we do have a referral, which is simply about connecting to an organisation, if someone wants to, say for example, with debt, they want some support, then that could be a matter of one appointment and relatively short if it's not complex. But because of the area we live in, and one thing we are all aware of is that the social prescribing landscape varies across the country, and the structures within which they work also vary. So some people have a lot less time to offer, some people have a lot more time to offer. Just really, really does, it is quite variable. I hope that answers the time question.
Yes, it does. And yeah, the guidance is 6 to 12 sort of interventions, if you like, over a 3-month period. But as Yasmin alludes to, that does vary. And we do sometimes see link workers working with people for up to a year, particularly those that have got more complex needs. But sometimes it can also be less than that. We have got just a question around any risks around because of the similarities between the roles. So is there a risk of role creep or working outside of scope, or potentially confusion for patients? And I think the main thing that I would say is that is exactly what this guidance is hoping and trying to mitigate. So hopefully some of the detail within that, when we share it with the recording of this webinar, will help provide some clarity specifically to that question. Ultimately, though, the most important thing is that we really build mutual understanding between roles and that open dialogue dialogue between link workers and occupational therapists as well. I don't know whether anybody else wanted to quickly. Kim, sorry, your hand's up. Thought I
I
saw a
just
hand.
wanted to come on the back of that. Thank you, Monica. Just yeah, to reiterate, Monica says we discussed that a lot within the guidance because I think that's one of the concerns quite often from both occupational therapists, social prescribers, and people around us. And we know as clinicians, we ask the doctor, what do you do? What do you do? And we have that shared aim. We all do in connecting and supporting people to live meaningful lives. But there is a clear distinction between both professions, but we complement each other. I always go back to the occupational therapist and looking at that functional assessment, and we can work well with social prescriber who's got that knowledge of community and what is out there. So combining their knowledge and the community and their skills with what's in the community to our knowledge and our expertise and function and combine that together can work really, really well. But it is a difficult one, and there is a risk of role creep. And I would always say one thing that definitely worked well with me when I started out primary care was I didn't know much about social scribes at that time then, is that I actually went and introduced myself. Let's talk about you. What's your day to day? This is a day to day for me. Where can we work well together? And just keeping it open and honest. And I think that works quite well. I hope that answers a little bit.
I think it does. That was, yeah, brilliantly summarised. Thank you, Kim. Unfortunately, we have run out of time. There is an opportunity for particularly the OTs that are on the call to get involved in our social prescribing champion scheme. So if you are particularly interested or want to learn more, there are e-learning modules that you can sign up to. It's just on the next slide. If we can go to that, Audrey. That you can sign up to that scheme to learn more about social prescribing. We will also share details of the Royal College of Occupational Therapists website along with and any other resources. Joe, do feel free to send those across so that we can include those as we mail this out. I understand that some people have had an issue potentially coming into this webinar, so apologies to anybody that is watching the recording. We will send it out to everybody that has signed up to this webinar, and as I said at the beginning of the call, host it on the NASP's website as well. All that leaves me to say is a huge thank you in particular to all of those at the Royal College of Occupational Therapists that have supported and worked with us on this guidance, and for all of the hard work that has gone on behind the scenes to make this happen, in particular to Joe, who has facilitated the workshops for this. It's been a joy to work with all of you, as well as you, Kim, Claire and Yasmin. It's just been absolutely wonderful to hear from your experiences and your insight, and we couldn't have written the guidance without that input. Thank you to Audrey and Govinda, who are busying away behind the scenes in this webinar, making sure that it runs smoothly. And of course, thank you to all of you. It's been great to just have an eye on the chat and see you all introducing each other, identifying where you might be able to collaborate, and asking some thoughtful questions that we will certainly continue the conversation through in future meetings as such. So for now, that just leaves me to say thank you once again, and see you next time. Thanks all.
Thanks so much, Monica.